All right, so I think we'll go ahead and get started. My name is Meredith. I'm a nurse practitioner. I'm a nurse practitioner over at Prairie. Dr. Jayaramaiah, did I say that right? Jayaramaiah?
Yes, yeah, that is right.
She is joining us from Joslin Diabetes Center, and she is going to be discussing with us diabetes and cardiovascular disease. Just so everyone knows, this will be recorded, so if you need to go back and watch it, or if you weren't able to join us live, you'll be able to. So I will turn it over to Dr. Jayaramaiah, and if you have any questions, go ahead and type them in the chat, and we'll get to those at the end. So go ahead, Dr. Jayaramaiah. Thank you so much for being willing to talk to us.
Thank you, Meredith. As she mentioned, my name is Purnima Jayaramaiah. I work with Joslin Diabetes Center at HSHS Medical Group. I have been working here for 12 years now, and diabetes is most of what I do. So today I'll be talking about diabetes and cardiovascular disease. Let me see. Oh, the slides are not advancing.
If you hit the right arrow on your keyboard, will it let you?
No, it's not actually. That's what I'm trying to do.
And if you click on the screen, will it let you?
Is it advancing now?
Yep.
Okay. Sorry about that.
That's okay.
So I do not have any financial conflicts to disclose. So the learning objectives today is mainly about diabetes, cardiovascular disease, and chronic kidney disease. To learn about the major drug classes in the cardiovascular outcome trials, mostly about the newer class of medicines, which is the SGLT2 inhibitors and the GLP-1 receptor agonists. I will start with a few questions, which I'll come back to in the end again. Question 1, in most patients with diabetes, chronic kidney disease should be attributable to diabetes if urine albumin creatinine ratio is greater than 250, 300, 350, or 400. Second question is, which medication class does not require renal dosing adjustment? SGLT2 inhibitors, which is Invokana, Jardiance, Farxiga, metformin, GLP-1 receptor agonist, which is Victoza, Ozempic, Trulicity, or ACE inhibitors. What constitutes glucose level for time in range? I'll talk about this in my presentation. 70 to 130 milligram per deciliter for blood sugar, or 70 to 180, 200 to 280, or 70 to 90. Diabetes is a coronary artery disease equivalent. I'm sure all of you know the answer for that. In patients with established cardiovascular disease, congestive heart failure, or who are at a high risk for these, adding SGLT2 inhibitor, even if the A1C is at goal or not. So diabetes, we know, is a chronic kidney disease, and it is the 7th leading cause of death in the United States. Adults aged 50 years or older with diabetes die 4.6 years earlier, develop disability 6 to 7 years earlier, and spend about 1 to 2 more years in disabled state than adults without diabetes. So far, more than 127 million patients have diabetes, and diagnosed diabetes is about 26 million. Undiagnosed is 9 million, and pre-diabetes is a big chunk, which is 91.8 million. So we need to identify these patients and try to prevent them or delay their progression from becoming a diabetic. So in studies as early as in 1998, there was a link between diabetes and risk of myocardial infarction. And now we know that diabetes is a coronary artery disease risk equivalent. So diabetes impacts cardiovascular risk. The higher the hemoglobin A1C, there is increased cardiovascular risk in patients. Of course, the duration of diabetes has a lot to do with the risk of cardiovascular risk also. Diabetes and cardiovascular disease together decreases the life expectancy of patients with diabetes. So the mechanism of coronary artery disease in patients with diabetes is more than just glucose. high blood sugars, insulin resistance, high cholesterol, thrombosis, inflammation, and infection. All these together leads to subclinical atherosclerosis and causes atherosclerotic clinical events. Type 2 diabetes increases the risk of congestive heart failure by 2 to 3-fold, increases risk of acute myocardial infarction, cardiovascular disease, peripheral vascular disease, and death. Diabetic kidney disease decreases life expectancy by 14.8 years in men and 16.9 years in women. So diabetic kidney disease is when patients with diabetes have a urine microalbumin creatinine ratio of more than 300 milligram per gram. As all of you know, the CKD stages, G1, G2, 3A, 3B, 4, and 5. We also calculate their urine albumin creatinine ratio. If it's less than 30 to 300 is moderately increased, and more than 300 is severely increased. So patients in the early stages in the green zone can be monitored. When they get to the yellow zone, we need to start making sure that we add medications to control their blood pressure, tighter blood sugar control, adding medication for kidney protection. When they get to the orange zones is when we refer them to nephrologists. So I'll start with a case. Dan is a 67-year-old African-American male with type 2 diabetes for 12 years. He has hyperlipidemia, hypertension, and chronic kidney disease stage G2A2. He does not always refill his medications on time, and mostly he says it's because he forgets to do that. Commercial coverage with high deductible, testing his glucose levels a few times a week, and his current medications are losartan, 50 milligram once a day, atorvastatin, 20 milligram once a day, metformin, 500 milligram twice a day, Januvia, 100 milligram once a day, and aspirin, 81 milligram once a day. On physical exam, his blood pressure is 150 over 94, which is clearly elevated. BMI is 32, which is in the obese range. Waist circumference is high at 43. Pertinent physical findings are loss of leg hair and lower extremity skin discoloration. His labs show that A1C is 8.4, which is clearly high. GFR is 66 with albumin creatinine ratio of 120. LDL cholesterol is 129, HDL 34, triglyceride 350. So Dan's lifestyle is mainly where he golfs and walks his dog once a day. He dines out at restaurant 3 to 4 times a week. He works at a trucking company and travels frequently, so he eats out a lot when he's traveling. Alcohol use on weekends, 5 to 6 beers. Tobacco use, he says he quit 15 years ago. He sleeps 6 to 7 hours at night, and he's not refilling his medications regularly. So goals of diabetes management. First, we need to define and achieve glycemic targets to reduce both microvascular and macrovascular events. So hemoglobin A1C target is the first thing we focus on. The target, the American Diabetes Association target is 6.5 for an A1C. ACE target is less than 7. But it's best to individualize the goals for each patient. The younger the patient, we try to keep the goal between 6.5 to 7. As patients are older, if they have multiple comorbidities, they're at a very high risk of hypoglycemia, or they live by themselves, we can relax the goal to as high as 7.5. For some patients, we even do 8 as the goal hemoglobin A1C. AGP is ambulatory glucose profile. That's like our EKG for endocrinologists. That is where we have blood sugar plot, which tells us what is their fasting blood sugar, what is their postprandial blood sugar, time and range, and glucose variability goals, which I'll talk to you later on when I show you some of the ambulatory glucose profile. But that's a good target to set for patients, which is easy for them to follow at home. So they can watch what their targets are at home even before they come to the office to find out what their A1C is. So type 2 diabetes therapies is mainly lifestyle interventions, Pharmacological intervention should be aimed at minimizing the risk of hypoglycemia and maximizing their time in range. And the time in range is between 70 to 180 for a blood sugar throughout the day. Also consider therapies for prevention or management of comorbidities like cardiovascular disease, hypertension, CHF, whether they will do better on aspirin, antiplatelet, and antihypertensives to prevent chronic kidney disease, ACE inhibitors and ARBs, dyslipidemia, statins, Zetia, fibrates, icosapentathiols, and PCSK9 inhibitors. Lifestyle changes, this is easier said than done. I'm sure all of you have had to do this in your practice. It's very hard to make lifestyle changes for any chronic health disease, but for diabetes, they have to constantly watch what they're eating, try to stay active, and they need a lot of motivation and help and support with this. So we start with setting SMART goals. SMART stands for specific, measurable, achievable, realistic, and time-sensitive goals. And our dietitians and diabetes educators really help them with setting small goals, which may be as small as if you're eating one carbohydrate at dinner, then try to skip another one, or try to cut back on sweetened beverages, at least by 50% if possible. Technology really helps us with this, which is checking their blood sugars, which motivates them that they're doing better, and try to watch their diet and exercise on a regular basis. CGM is continuous glucose monitors, which I'll talk about more in later on slides. There are many apps now to monitor how much activity you're doing, what you're eating, how many carbs, calories a day to keep you moving. Online portals is mainly stuff like MyChart, where patients send blood sugars every week. Some pregnant patients send blood sugar every 3 days for us to monitor and watch their glycemic variability and adjust their doses. Behavioral change, we try our best not to use fear, especially we never tell patients that if you don't do this, we'll start you on insulin, because eventually most of the patients will have to go on insulin because diabetes is a progressive disease, and we don't want them to feel that it was their fault that they did not take care of their diabetes and now they have to go on insulin, then they won't take insulin. Try to provide encouragement. And we have to find out what is the biggest challenge or barriers for patients to manage their diabetes, which may be multiple, as in this slide. Many times patients tell us they're not taking their medications because they forget. I've had patients tell me that they don't want to take insulin in public, so they don't take insulin multiple times. They don't like the pain that they have to go through, and most of the patients are in denial. They feel that if they don't check their blood sugars, if they don't take their insulin, the diabetes will go away. So for Dan, the lifestyle or the behavioral changes that would help will be instead of taking a golf cart, he can walk the course or take the dog out twice a day instead of doing it once a day. When he dines out at a restaurant, drinking a big glass of water before he starts his food, or selecting baked or grilled items. Take half the food home. And when you order food, you can order the sauces and the dressings on the side rather than everything mixed up. Alcohol, he can decrease the alcohol intake to 1 to 2 beers on the weekend instead of 5 to 6. And filling prescriptions 90-day really helps, because they use that as an excuse sometimes that I ran out of pills, so I did not have time to go pick up the prescription. So pharmacological options for Dan would be to maximize his diabetes control and try to get his A1C to less than 7. His blood pressure, as you saw, was elevated, so we can adjust his blood pressure medications and use some of the diabetes medication, which will help with decreasing blood pressure too. Lipid control, he needs to be on a higher dose statin. Weight management is key to all the above management. So the ominous octet is how hyperglycemia happens, which is not just what you eat and the glucose influx, but also diabetics have increased glucagon secretion from the pancreas, this decreased insulin secretion, neurotransmitter dysfunction, decreased peripheral glucose uptake, which is a part of insulin resistance in type 2 diabetics, renal glucose excretion, which is where medicines like SGLT2 inhibitors, the Invokana and the Jardiance work, and increased hepatic glucose output. And I have listed here how each medications affect in improving diabetes control. So coming back to the goals of diabetes management, earlier we always focused on a hemoglobin A1C and tried to say your A1C should be less than 7% or 6.5%. But now we've learned that A1C is just an average of blood sugars. So it is an average blood sugar of 154. I have three different scenarios here where all three patients have a hemoglobin A1C of 7, which is an average blood sugar of 154. But the first one, if you see, their blood sugar varies from 50 to 350 and then back down to 50. They have this roller coaster ride with 40% blood sugars in range, which is between 70 to 180. 40% blood sugars are high, and they're having 20% low blood sugars, which is significant low blood sugars. But if you check their A1C, it is 7, so it looks like they're doing really well. The second patient is where 70% of blood sugars are in range, which is good, 25% high blood sugars, and they're having 5% low blood sugars, which is still high, but better than the first patient, and he has an A1C of 7. The third patient, 100% of blood sugars are in range, which would be perfect, which we don't see very often. So ambulatory glucose profile, since we use a lot of continuous glucose monitor these days, even with the blood glucose monitors, we can print the profile and download this, where it will tell us what percentage of time blood sugars are in range, which is 70 to 180. So the goal is to keep type 1 and type 2 diabetics in range 70% of the time, try to minimize their hypoglycemic episodes, which is a blood sugar of less than 70 to less than 4%, and to minimize their very bad hypoglycemia or severe hypoglycemic episodes, which is less than 54 to less than 1%. They will always have some high blood sugars above 180, but it's best to minimize that to less than 25%, less than 5% for blood sugars more than 250. For older patients who are at a higher risk for hypoglycemia, we try to target or keep the time in range at 50%, and they can have 50% high blood sugars, which is between 180 to 250, and try to minimize their low blood sugars less than 70% to less than 70 to less than 1%. For pregnant patients and type 1 diabetes patients, again, 70% in range, and they tend to have a little more hypoglycemia. For patients with gestational diabetes, we try to keep their blood sugars as much as possible in range, which is almost close to 90%. So the goal time in range is 70%, and the target or the time in range is 70 to 180. So macrovascular risk reduction in type 2 diabetes is mainly glycemic control, blood pressure control, cholesterol, aspirin therapy, smoking cessation, lifestyle modification, and weight loss. So previous landmark trials for diabetes and macrovascular risk in type 2 diabetes patients has shown that it decreases non-fatal MI, any cardiovascular event, stroke, but all-cause mortality was not as much affected. So we knew that tightening glycemic control, intensive glycemic control decreases the risk of microvascular event, but it did not affect macrovascular events as much. So the newer diabetic drugs, which is SGLT2 inhibitors and GLP-1 receptor agonists, have consistently shown cardiovascular and renal protection in large cardiovascular outcome trials. Metformin is also one of the medications which has been shown to decrease macrovascular risk. So I'm going to discuss only the newer pharmacological treatments for type 2 diabetes, and the two classes are SGLT2 inhibitors and the GLP-1 receptor agonists. So I'll talk about mechanism of action, cardiovascular outcome trials, benefits, adverse events, and dosing and adjustment in patients with chronic kidney disease. So SGLT2 inhibitors are canagliflozin or Invokana, empagliflozin Jardiance, dapagliflozin Farxiga, and ertugliflozin Stiglatro. The GLP-1 receptor agonists are liraglutide or Victoza, dulaglutide, which is Trulicity, semaglutide or Ozempic. It's also available as an oral medication, which is Rybelsus. Albiglutide is not available in the United States. So SGLT2 inhibitors and GLP-1 receptor agonists decrease oxidative stress-induced endothelial cell dysfunction, decreases inflammation and atherogenesis. It has a glucose-lowering effect, natriuretic effect, and renin-angiotensin-aldosterone system effect. SGLT2 inhibitors, in addition, have a uricosuric effect, and it increases beta-hydroxybutyric acid, which is why we have to be careful with SGLT2 inhibitors in patients with type 1 diabetes or patients who are on a keto diet, as they can be at a high risk of going into diabetic ketoacidosis. So SGLT2 inhibitors not only improve blood sugars, but also do not cause low blood sugar reactions. Because it helps you excrete sugar only when the sugar is high in your blood. It causes weight loss of about 1 to 3 kilograms, decreases blood pressure, decreases triglyceride. It's the oral medication as opposed to the GLP-1 receptor agonist, and it provides cardiac and renal protection. So earlier, we thought that if we decreased blood sugars with medications, it improved outcomes. But after medications like the TZDs, the thiazolidinediones, or the rosiglitazone, which was also called Avandia, we learned that even though it was very good for diabetes control, it had adverse cardiovascular events. So after 2008, FDA and European Medical Association came out with guidelines where all new diabetes medications have to go through cardiovascular outcome trials and prove non-inferiority or superiority for cardiovascular events. So now we have multiple cardiovascular safety studies with both SGLT2 inhibitors and GLP-1 receptor agonists, which have proven non-inferiority and superiority. SGLT2 inhibitors provide cardiovascular protection by reducing preload and afterload. It improves anti-inflammatory and pro-inflammatory cytokines, reduces cardiac fibrosis, increases hematocrit and erythropoietin production, increases cardiac metabolic efficiency. Kidney protection is mainly because of glucosuria, natriuresis, decreased glomerular pressure, and reduced albuminuria. SGLT2 inhibitors decrease the absorption of glucose and sodium, which is why they cause natriuresis and glycosuria. And the greatest rate of glycosuria occurs after patients have hyperglycemia. So if a patient is taking SGLT2 inhibitors like Jardiance and they eat a big meal with a high carbohydrate load, their blood sugar goes up and they have to go to the bathroom more frequently. A few hours later, have to urinate more because of hyperglycemia causing glycosuria. The risk of hypoglycemia is not significant with SGLT2 inhibitors. So the studies with SGLT2 inhibitors, the cardiovascular outcome trials, is the EMPA-REG study, which was with empagliflozin or Jardiance. It showed that there was a decrease in 3-point MACE, which is composite of death from cardiovascular cause, non-fatal MI, and non-fatal stroke. There was significant decrease in cardiovascular death and hospitalization due to heart failure. Canvas study showed decrease in MACE, but not significant change in cardiovascular death and heart failure. This was with Invokana. Dapagliflozin significantly decreased the hospitalization with heart failure, and Vertis was with ertugliflozin, which showed non-inferiority. There are also 2 studies with SGLT2 inhibitors and in patients with proteinuria. Most of them were diabetics in patients with the Credence trial. The DAPA-CKD, there were 32% of patients who did not have diabetes. And this showed that there was renal protection in patients who were on SGLT2 inhibitors with prevention or protection of their GFR. And it prevented the decline in GFR and decreased microalbuminuria. SGLT2 inhibitors in patients with heart failure and reduced ejection fraction. There were two studies. One is the DAPA heart failure study and the Emperor heart failure study. Both of them had 50% non-diabetic patients, and it showed that there was decrease in cardiovascular death, urgent visit, or hospitalization for heart failure. There was significant decrease in cardiovascular death and all-cause mortality in both. So SGLT2 inhibitors, summary of the cardiovascular outcome trial is that patients with type 2 diabetes with or without established cardiovascular disease, it decreased hospitalization for heart failure and provided renal protection. Type 2 diabetes patients who had established cardiovascular disease, there was a decreased 3-point MACE, reduced hospitalization for heart failure, renal protection. In some cases, there was decreased mortality, which was mainly with Empereg, that is Jardiance and Invokana. Cardiorenal benefit also was shown in patients without diabetes, in patients in the DAPA-CKD, DAPA heart failure, and Emperor heart failure trial. The most common side effects we see with SGLT2 inhibitors is genital mycotic infections, urinary tract infections, polyuria, volume depletion, hypotension, and dizziness, increased LDL, increased creatinine, euglycemic DKA, like I mentioned before, increased rate of lower extremity amputation, which was seen with Invokana in the Canvas study, but it was not seen in the Credence trial. Side effect of Fournier's gangrene is rare, and there is an increased risk of bone fractures with these medications. Most common side effects that I see in my practice is patients, especially women, tend to have bladder infections. And if they develop 2 to 3 bladder infections, I usually stop the medication. But even before I start them on this medicine, I tell them that they need to make sure they drink enough water. And if they have any problems with dizziness or low blood pressure, then I try to adjust the medicine accordingly. SGLT2 inhibitors have to be dosed based on GFR. Invokana, the 100 and the 300 milligram can be started if their GFR is less than 60. It can be continued even if their GFR is less than 45. In the studies in the Credence and Canvas, there were patients whose GFR was as low as 30, and they did well without any side effects. Farxiga, you can start if it is less than 45. It can be continued if it is 30. Jardiance is just like the Farxiga. Ertugliflozin, it can be started if it's less than 60. So next is the GLP-1 receptor agonist, which I use more in my practice than the SGLT2 inhibitors. The main difference for me between these two in terms of glycemic control is GLP-1 receptor agonists are more potent. They decrease A1C by up to 2%. And I've seen even more reduction in A1C in patients with GLP-1 receptor agonists. So the earlier medicines we used was Byetta, which I really don't use anymore. It causes significant nausea. It's very hard to take exactly half an hour before each meal. Bydureon is a longer acting Byetta, which is once a week injection, which is better tolerated than Byetta. Victoza or liraglutide is once a day injection, a GLP-1 receptor agonist. Lexisinatide is not available separately, but it's available as a combination with a long-acting insulin, which is an injection once a day. Semaglutide is Ozempic, which is injection once a week. Rybelsus is an oral medication once a day. Dulaglutide or Trulicity is once a week GLP-1 receptor agonist. So these medicines offer cardioprotection because GLP-1 receptor is expressed in cardiomyocytes and coronary endothelial cells, and it improves left ventricular and endothelial function. So GLP-1 receptor agonists not only decrease the glucose production and it decreases the risk of hypoglycemia, it mainly makes patients feel full. They're not as hungry, which is one of the main problem in patients with type 2 diabetes with very high blood sugars is they're always hungry. And once they start this medicine, their appetite goes down, their snacking goes down, which improves the insulin resistance. And as they lose weight, their blood sugar improves and their insulin resistance improves. Most of the time, I can take patients off other medications once they do really well on this medicine. It also decreases coagulation, decreases postprandial lipids, decreases inflammation, body weight. This is the major advantage of GLP-1 receptor agonists compared to other medications. It decreases blood pressure, causes mild natriuresis and diuresis, and cardioprotection. So there are many cardiovascular outcome trials with most of the GLP-1 receptor agonists. All trials met non-inferiority. There was superiority for MACE with liraglutide, which is Victoza, semaglutide or Ozempic, albiglutide, and Trulicity or dulaglutide. There was reduced ischemic events of stroke and MI, kidney protection. There was potential benefit for heart failure hospitalization, but it was a small effect in a meta-analysis. There was mortality benefit seen mainly with liraglutide in the LEADER trial. So GLP-1 receptor agonist benefit is it decreases postprandial glucose excursions. Weight loss is a major advantage. It increases satiety, decreases cholesterol, does not cause hypoglycemia unless they're taking other medications or insulin, which can cause hypoglycemia. It provides cardiac and renal protection. And it really does not need change in patients with chronic kidney disease. We can start patients with a GFR of 30 or less than 45. Most common adverse events are GI side effects, mainly because of the mechanism of action. It decreases the gastric emptying, so food stays in the stomach for a longer time, and patients feel nauseous, especially if they eat a fatty meal. They feel more nauseous. Diarrhea in few patients, increased heart rate. I've really not seen this in many patients. If patient has medullary thyroid cancer, you cannot start them on GLP-1 receptor agonist, but that is rare. If patients already have had pancreatitis, I would not start those patients on GLP-1 receptor agonist. So the medications, like I already mentioned before, is Byetta, Bydureon, Victoza, Lexacinetide, Ozempic, Rybelsus, and Trulicity. So the main decision making whether I start patients on SGLT2 inhibitors or GLP-1 receptor agonists depends on their comorbidities. If they have atherosclerotic cardiovascular disease or stroke, then I would try to choose GLP-1 receptor agonists with proven benefit. If it's heart failure or CKD, then it's best to choose SGLT2 inhibitors with proven benefit. So now the guidelines have been updated, and even in type 2 diabetes drug naive patients, we can start patients with GLP-1 receptor agonists or SGLT2 as a monotherapy, and the first line agent or metformin can be started. It can also be added on at a later time. The next few slides are busy slides, which is glycemic control algorithms, where again, these medications can be added if A1C is less than 7.5, 7.5 to 9, more than 9, most of the times it is insulin. This is about how different medicines affect weight, cardiovascular effect, bone, and ketoacidosis. So this is a very informative slide where there's indicators for high risk for cardiovascular disease, CKD, or heart failure, when to choose these medications as opposed to other medicines. Cost is a major issue with both these medicines, SGLT2 inhibitors and GLP-1 receptor agonists. Medicare usually does not cover, unfortunately, both medications. But for non-Medicare patients, I've not had any trouble. So diabetes is a multifactorial disease, and the latest guidelines recommend SGLT2 inhibitors and GLP-1 receptor agonists for organ protection and individualized diabetes care. Coming back to Dan, his metformin was 500 milligram twice a day. So we can increase his metformin to 1,000 milligram twice a day, which will improve his glycemic control. GLP-1 receptor agonist is what I would choose for as a first agent for him after metformin, because it will help with weight reduction, improvement in blood sugars, improvement in cholesterol and blood pressure. And if his blood sugars and his glycemic target are not met, then I would consider adding SGLT2 inhibitors in addition to that. And even if his A1C is at goal, it is good to add SGLT2 inhibitors for renal and cardiovascular protection. High blood pressure, lipid, and he definitely needs to be on a high dose or high intensity statin. His goal A1C would be less than 7. His goal LDL cholesterol would be less than 70. Goal blood pressure would be 130/80. So I would like to talk a little bit about tools for monitoring, as these things have changed significantly over the last 5 to 6 years. We do a lot of continuous glucose monitoring on patients, which is available as professional continuous glucose monitoring, which we place on the patients in the clinic for 10 days or for 2 weeks. Personal CGM is where patients can buy their own CGM, which most of the insurances cover, and they can use it for feedback as to how they're doing with their diabetes control and also adjusting their insulin doses. So we have different continuous glucose monitors. This is Medtronic sensor with the Medtronic insulin pump. This is the Freestyle Libre, which I'm sure you've seen on TV and on patients, where you use the phone to scan to see what your blood sugars are. This is an implantable sensor, which is called Eversense, which is implanted under the skin, and it stays there for 3 months and it records your blood sugars. This is the Dexcom, which we use very commonly. These are CGM reports that we print. This is our EKG. This is average blood sugar. It tells us what their A1C would be based on the blood sugars, time in range, time below range, and time above range. And these fluctuations help us adjust their medications, help them with lifestyle changes, dietary changes. So this is an example of how we can change the graph. Like for this patient, he was eating a small breakfast, a big lunch, and a small dinner, and making small changes in his lunch, as small as maybe skipping one piece of bread or cutting back on the fries that he was eating at lunch, can bring his numbers down, and patients can see the targets at home. They have this app on the phone, so they can see how their targets are improving every week, which is very motivating for them to stay on top of things. We can do similar downloads with Meter, which will give us what is their time in range and time above range. I will end with a couple of practice patients. 52-year-old male presents for follow-up of his diabetes shortly after a recent hospitalization for MI and status post 2 cardiac stents. He's currently feeling well. He has been taking metformin 1,000 milligram twice a day and glipizide 5 milligram once a day for diabetes. Hemoglobin A1C is 6.7. He denies any hypoglycemic events at home and reports home blood glucose monitoring values of 78 to 120. BMI is 32, which is clearly high. What would you recommend to patients regarding his diabetes therapy at this time? Choices are no change to therapy as diabetes is well controlled. Increase glipizide to 5 milligram twice a day and reduce A1C to less than 6.5%. Add basal insulin for tighter glycemic control. Add GLP-1 receptor agonist and discontinue glipizide. The best thing to do for this patient would be to add GLP-1 receptor agonist and discontinue glipizide. GLP-1 receptor agonist will decrease his weight and decrease his blood sugars, provide cardiovascular protection. And GLP-1 receptor agonists are very potent, so you will have to discontinue glipizide, otherwise he can have more hypoglycemic episodes. Next is a patient who is 49-year-old male who's seen in the emergency department for skin infection. His lab work is notable for hemoglobin A1C of 7.5%. He has not seen a doctor for several years, but reports having a history of MI in his early 40s. He was never told of diabetes or prediabetes in the past. He has no medical insurance, and he mentions having trouble paying his rent. He usually eats fast food and notes that it is most affordable option for him. What would you recommend for his diabetes therapy? Clearly, he has diabetes with an A1C of 7.5%. The choices are lifestyle modification and metformin, lifestyle modification and SGLT2 inhibitors, lifestyle modification and GLP-1 receptor agonists, lifestyle modification, SGLT2 and GLP-1 receptor agonists. So the best one for him would be lifestyle modification and metformin, mainly due to cost. Metformin would probably be able to bring his A1C down from 7.5 to 6.5%, and it is very inexpensive and provides cardiovascular protection. So back to the questions I started in the beginning. So in most patients with diabetes, chronic kidney disease should be attributable to diabetes if urine microbial creatinine ratio is greater than, the answer is 300. Which medication class does not require renal dosing adjustment? It is GLP-1 receptor agonists. Although the older medications like Biotin, Bidorion cannot be taken if GFR is less than 30. What constitutes glucose level for time in range? It's 70 to 180. Diabetes is a coronary artery disease equivalent. Answer is yes. In patients with established cardiovascular disease, congestive heart failure, or high risk for this, adding SGLT2 inhibitors, even if A1C is at goal, the answer is yes. Any questions? I'm sorry, that was a lot of information too fast.
That was really great. Thank you so much, Dr. J. I do have a question about starting patients on these medications whenever they're on insulin or something like glipizide. So I just want to know kind of what your rule of thumb is as far as starting those medications and then discontinuing or decreasing glipizide or insulin or really any other diabetic medication.
Are you asking about SGLT2 inhibitors or GLP-1 receptor agonists?
Both would be great. Give us your rule of thumb for either one or both of them, please.
So if I do SGLT2 inhibitors and like say their A1C is 7.5 and they're on insulin and glipizide and I'm adding SGLT2 inhibitors, I really don't make any changes. SGLT2 inhibitors decrease their A1C by 0.6 to 0.7%. So I would wait and watch. I would ask the patient to call back in a couple of weeks if they have any blood sugar less than 70. And if they do, then I would first take them off of glipizide or decrease their glipizide by 50%, see what happens for another 2 weeks. If they still have low blood sugars, then I would take them off glipizide. With GLP-1 receptor agonists, it's different. Like I said, they are much more potent for blood sugar control than SGLT2 inhibitors. So if patient's hemoglobin A1C is 9, and I'm adding SGLT2 inhibitors to glipizide and insulin, I would not make a change. I would ask them to call back, and I would slowly decrease their glipizide and insulin as their blood sugars improve. But if their A1C was 7.5, and I'm adding a GLP-1 receptor agonist, I don't want them to have low blood sugars and they will go off the medicine. So I definitely will discontinue glipizide. Insulin, I will based on how they're doing. Sometimes it's not a bad idea to give patients some guidance that if their blood sugar starts dropping down to 70, then they can decrease their insulin by 4 units every 2 to 3 days. That way they feel like they are in control, and as they come off the insulin, it motivates them so much more to do better. I hope that helps.
That definitely helps a lot. Does anybody else have any other questions for Dr. J? Okay, well, I think that about covers it. And Dr. J, thank you so much again for speaking to our APPs and nurses. I know that was so helpful for me, and I'll be watching it again in the future, just because there's a lot of information to take in, but we really appreciate you speaking to us. So
Sure.
thank you so much.
Sure. Thank you.
All right. Thank you, everyone. Have a good day.
Thank you, everyone. Have a good day.